Hello, good day to everyone. My name is Nikki, and with Maddie, we will be presenting our problem-based learning on the neurological section for Section 10 of Advanced Assessment Practicum.
All right, so in our case, we have a 45-year-old African-American male. He's presenting to the urgent care clinic with a chief complaint of a 5-day history of headaches, weakness, and an unsteady gait. Recently, the patient was seen and treated at the very same urgent care about 7 days ago. He had a cough. He was treated with amoxicillin. So since then, his cough has been better, kind of resolved, but now he's having these above symptoms of headache, weakness, and unsteady gait that are making him feel even worse than the original cough of 7 days ago. Also, the patient has been experiencing a fever, usually at nighttime, as well as a stiff neck as he is unable to touch his chest with his chin. The patient is a source of information that was given forthcoming and appears reliable, and no interpreter was used as the patient speaks English.
The patient's past medical history includes the following, and I will highlight a few from each category. The patient denies any childhood illnesses, but during adulthood, the patient was diagnosed with sickle cell disease at age 35. Health maintenance with the patient's poor access to healthcare and his sickle cell disease. The patient is currently on unemployment disability due to his inability to perform job duties as a mechanic due to the chronic pain from sickle cell disease. In terms of medications, the patient takes hydroxyurea, 1,500 milligrams orally daily for sickle cell disease. The patient also takes fish oil capsule, 100 milligrams daily, as well as a multivitamin daily and ibuprofen PRN. Significant drug allergies to codeine with a patient's response of nausea and vomiting. Denies any other food or environmental allergies. Family history of this patient includes both the father and mother having sickle cell disease. Both parents are alive. Patient has one sibling, a brother, who also has sickle cell disease, and both maternal and paternal grandparents are deceased and died from old age. Personal history, the patient is born and raised in Los Angeles, male sex at birth, identifies as a male, highest education is a GED. After finishing high school, the patient works as a mechanic where he worked for the last 20 years. Currently lives in a 2-bedroom apartment in Los Angeles with his monogamous husband, and he is sexually active, drinks 2 cups of coffee a day, 2 cups of soda a day, 2 alcoholic drinks a week, and denies smoking and any other illicit drug use.
All right, so next we have the review of systems. So starting out with general or constitutional, the patient is positive for having fever, especially at nighttime. He's positive for decreased appetite, and he's negative for reports feeling generally well, because he does not feel well. Next, we're moving on to head, eyes, ears, nose, and throat. Again, he's positive for headache, positive for dizziness, positive for lightheadedness, and positive for photophobia, or the discomfort of bright flashes or bright light on the eyes. Next, moving down to neck. He's positive for neck pain and a stiff neck. Remember, he cannot touch his chin to his chest. And next, moving on to respiratory. He still has a little bit of a cough. And everything else on the review of systems is looking negative as of now.
In continuing with review of systems, in terms of GI, the patient reports worsening appetite. In terms of GU, Mostly within defined limits, the patient does report the use of condoms. Musculoskeletal significance issues there with reports of joint pain, muscle stiffness, neck stiffness, ataxia, and muscle weakness. In terms of psychiatric, the patient reports anxiety and nervousness. In terms of neurological, the patient reports fatigue and weakness. And hematological, patient does have a history of sickle cell trait. In terms of endocrine, everything is within defined limits.
Next, we're going to be looking at the objective data in the physical examination. We're starting off with the vital signs. You can see that temperature is raised at 101, respiratory rate is 18, heart rate is a little elevated at 112, BP is 120/72, O2 is 100, and he's having 10 out of 10 pain located on the neck. As we move on through the objective data, you can see here the patient is 6 foot, his weight is 200 pounds, BMI is 27.1. Patient is a middle-aged man who appears weak and in some acute distress. He's pretty anxious, but overall he's well-groomed with proper hygiene noted. Speech is clear, patient is alert and oriented, and appears a stated age. Moving on to skin. Skin is looking good. It's warm, dry, good skin trigger. Skin is intact, cap refill is less than 3 seconds. There's no abnormalities found here. Moving on to head, eyes, ears, nose, and throat. The most critical observation and objective data is that he's having eye discomfort when exposed to light, otherwise known as photophobia. Moving on to the neck, nuchal rigidity is found as the patient cannot touch his chest with his chin. Thyroid is barely palpable. Other than that, the neck is supple with a trachea midline. Moving on to the thorax and lungs, the chest is appropriate in size and shape. It's symmetrical, there's good expansion, there's downward sloping of the ribs, no use of accessory muscles. He's not in distress currently. He's breathing unlabored and quiet. Moving on to cardiovascular, there is some sinus tachycardia again at 112, but there are no abnormal heaves, lifts, or pulsations. The apical pulse is felt at the midclavicular line and the fifth intercostal space. No S3 and no S4 are heard. EKG was completed. There was no ST changes.
Continuing on with objective data, peripherally, the patient does not have any JVD. The jugular venous pressure measures at 4 centimeters. There are no carotid artery bruits, auscultated bilaterally, and all peripheral pulses are +2 without thrill. Abdominally, the patient's abdomen on inspection is uniform in color, round, and soft. Upon auscultation, there are normal active bowel sounds in all 4 quadrants. When palpating the liver, it measures 8 centimeters at the midclavicular line and 1 centimeter below the right costal margin, which is smooth and palpable. The patient also denies CVA tenderness. There are no hernias. In terms of genitalia, the glands is within defined limits. Meatus is visualized without discharge. The foreskin was retracted and is able to retract back on its own. Patient's testes measures approximately 4 centimeters by 4 centimeters. There are no edema, masses, or hernias. Rectally, there are no external hemorrhoids, external fissures, or skin tags. There is a tight sphincter tone. The patient reports his stool is brown and is also negative for occult blood. Musculoskeletal-wise is significant. Patient does have full range of motion in all 4 extremities. However, there is limited range of motion in the neck and is unable to touch the chest with his chin. Patient also has impaired coordination with an unsteady gait and balance. Patient does exhibit a positive Brodsky sign and a positive Koenig sign. terms of neuropsychiatric, the patient is alert and oriented, normal affect, normal mood, appears anxious and is cooperative, speech is linear and coherent. And other findings is his NIHSS is a 2 due to the ataxia and has a GCS of 15.
All right, so based on the objective data and everything that we've gathered, we're going to run some laboratory and diagnostic studies. First, we're going to start off with a lumbar puncture with a CSF, cerebrospinal fluid analysis. You can see everything highlighted in orange, or the red color, is the abnormality. So the CFF indicates an elevated WBC, an elevated differential, elevated protein, decreased glucose, really low CSF serum ratio, a positive CSF stain, and there is the opening pressure. We're also going to do a standard CBC. We're going to run a blood culture, which came back positive, a CT of the head, which came back negative, TB gold, which tests for tuberculosis, that also came back negative, EEG of the brain came back negative, and a chest x-ray for any abnormalities, which came back negative.
In this slide, we will be discussing the CSF findings from a lumbar puncture, and we will be highlighting the second column for the bacterial infection. And what's significant about this is that there is WBC present, and the other significant finding here is that the glucose is decreased, which suggests a bacterial infection. In this slide, we will be discussing the CSF.
These are our differential diagnoses. Currently, our primary and working diagnosis is bacterial meningitis. This is mostly due to the positive cerebrospinal fluid results, along with the signs and symptoms of fever, nuchal rigidity, which is neck stiffness, and photophobia. Some of our other differentials were viral meningitis, which is very similar signs and symptoms to bacterial meningitis, but based on the CSF results, it would indicate bacterial rather than viral. Another diagnosis was encephalitis, which could be seen with photophobia, fever, muscle stiffness. But because the EKG was negative and the positive CSF results came back, we're going to rule this one out. Next is tuberculosis, indicated for night fevers, prior cough, muscle stiffness, but we're going to rule this one out because of the TB gold negative. And last was the hemorrhagic stroke, which is indicated for headache and ataxia, but we're also going to rule this one out due to the CT of the head being negative, the EEG was negative, and the CSF results.
So after the differential diagnoses has been presented, we will be discussing our working diagnoses, which is bacterial meningitis. And the pathophysiology of bacterial meningitis is inflammation of the brain, spinal cord, meninges, and the CSF, in which bacteria crosses over the blood-brain barrier and releases a cytokine release, which leads to platelet activating factor that triggers a clotting cascade, which then forms microthrombi, which then leads to another cytokine cascade, which ultimately leads to vasodilation and vascular permeability, which leads to a compromised blood-brain barrier that allows the entry of other blood components. The increased permeability contributes to the development of cerebral edema and increased intracranial pressure, which is responsible for the clinical signs and symptoms of meningitis. On the other hand, we have signs and symptoms. Patients will manifest with a headache, fever, neck stiffness, altered mental status, seizures, abnormal CSF findings, photophobia, nuchal rigidity, with a positive Kernig sign and positive Brzezinski sign.
All right, next we're going to talk about the prevalence and risk and which populations are most at risk for bacterial meningitis. First off, CNS infections as a whole are pretty uncommon and declining in incidence with a rate of 0.8 per 100K individuals between 1997 and 2010. But CNS infections are still very severe and require prompt medical intervention and treatment. With that being said, bacterial meningitis is the most common of the CNS infection, the mortality rate of approximately 15%. And if the individual does survive, between 10 to 30% of those survivors are afflicted with neurological impairments, which can be permanent, including hearing loss, hemiparesis, and learning disabilities. There are several risk factors for CNS infections, including bacterial meningitis. This includes recent exposure, close contact with another individual who has the infection, recent infection like otitis media, immunosuppression, surgery trauma, and being unvaccinated. And the populations that are most at risk are young children, which are less than a year old, college students living together, immunocompromised individuals, and unvaccinated individuals. For the assessment and plan of our 45-year-old patient, the first thing we're going to do is initiate droplet precautions, as meningitis is spread this way. This can be coughing, spitting, sputum related. And we're also going to initiate airborne precautions. We know TB Gold came back negative and the chest x-ray came back negative as well, but we do want to follow up with an AFB test just to be sure. Next, we're going to start very promptly treatment of IV high dose antibiotic therapy, which is the first step and is essential due to the high morbidity and mortality associated with bacterial meningitis. It was found that S. pseudomonas was the specific bacteria, so we're going to treat that with vancomycin 15 milligrams per kilogram plus ceftriaxone 1 milligram per liter every 8 to 12 hours. This is done primarily due to the increase in pneumococcal resistance to high dose penicillin G, which was originally the first line. Next, we're also going to initiate fluid resuscitation as part of supportive measures for dehydration for our patient. And we're also going to initiate analgesics, ibuprofen 400 milligrams for the pain that he's feeling. We're going to do this every 6 hours. And we're also going to follow up on intracranial pressure, determine if the patient has ICP, which is elevated. This can be often observed in patients with meningitis and can be treated with antihistamines, raising the head of the bed at least 30 degrees and decreasing environmental stimuli. But first, we're going to figure out if he does have ICP increased.
In terms of education for a patient and family members that are seeking medical attention for bacterial meningitis, we should stress the importance that other household members that have been exposed to the patient may need to take antibiotics. Also, simple hygiene practices such as washing hands and avoiding sharing cups or silverware. And also below, we have listed the vaccine schedule, which is the recommendations by the Centers for Disease Control and Prevention, or the CDC. In terms of
and these are our references for our PBL here. Thank you so much for your time. And that's it.